What about the withheld diagnoses? It seems like every dementia conference that I've attended over the past few years has had a presentation by Graham Stokes from Bupa in the UK, talking about the statistic that GPs tend not to give 50% of the people that they believe to have dementia a diagnosis. And he's also described all the efforts that have been made in the UK to improve on this, mostly unsuccessfully. People have put in all sorts of educational programs to make GPs more confident in giving diagnoses, but the figure remains stubbornly around the 50%, maybe because it's not about a lack of knowledge. The UK government, despairing of the educational approach, a couple of years ago decided to try bribery. Now, some of you are GPs, so I'm assuming that bribery isn't really a very effective way of working with you. The UK government seem to be working on the basis that if you are sitting in your consulting room with Mrs. Smith, who lives by herself and has family on the far side of the country, and you believe that she has dementia, and that if you give her a diagnosis of dementia, you're going to distress her for as long as she remembers that she has the diagnosis, and you're going to destabilize her family, who are then going to have to decide between traveling across the country to care for her or worrying about her and everything. Or you have the option of just letting Mrs. Smith carry on with her life. She's not harming anybody. Chances are she may forget to come for her next flu jab, and nature will take its course. But the kids haven't seen Spider-Man yet, and that £55 would be a few cinema tickets. So what the hell? Let's give Mrs. Smith her diagnosis of dementia and go to the cinema. I think I'm right in saying that you guys don't think like that. Most of the studies that have been done on GPs' motivations for withholding diagnoses have been about care, about not wanting to distress people, about not wanting to destabilize situations. As I said, I gave the illustration there of letting nature take its course. I was struck by the fact that 50% of older people live alone and 50% of diagnoses are withheld. So I asked a very senior clinician in the dementia field whether it was possible, not Jan, for reasons that will become obvious, you'll realize why in a second, was it possible that people could be going through this decision-making process, saying that it was kinder just to let people decline naturally and let nature take its course? And she said, yes, it was perfectly possible, because when she was a GP, that's what she did. Now, what about the false diagnoses? How can the rate of false diagnosis be so high? When I was training back in the 1990s, it was very important to distinguish dementia from depression. I regularly get referrals to assess people to comment on whether it was possible that this person who appeared to have dementia might instead have depression, because it would be terrible if anyone who had depression was deprived of the opportunity to benefit from antidepressant medication. Later on, when the antidepressants were no longer a profitable drug class, but the new anti-dementia drugs came in, there seems to have been a change in the priorities of researchers. And now the priority seems to be identifying as many people as possible, as early as possible, who might be prescribed these new profitable drugs. And the focus on distinguishing dementia from depression, the focus on the accuracy of the diagnosis, seems to have been lost. Now, I wondered whether that sort of perspective was just me being cynical. I thought it's entirely possible, having been out of academia myself for so many years, that my research skills had just failed and I wasn't finding the studies. What I did find was a report from the World Health Organization making the same complaint, that in the previous 10 years there didn't seem to have been very many studies on the accuracy of dementia diagnoses. Why is this important? It's important because someone misdiagnosed with dementia is not only being treated for a condition that they don't have, they're not being treated for whatever it is that they do have that made you think they had dementia. There was a question before about life expectancy. The orange bars are the life expectancies for New Zealanders today in each age group, and the black bars are the life expectancies for people with dementia of that age. At any age, dementia is a life-shortening condition. And so we really need to be sure that we're not consigning people. It's a life-shortening condition, and don't have time today to inflict the maths on you, but if you look at the studies of survival time after diagnosis, and you look at the relative rates of misdiagnosis that are likely in the different types of studies, the only way to reconcile all the figures is if people with a misdiagnosis have the same life expectancy as the people with a true diagnosis of dementia. So we really need to know who we're misdiagnosing. Now, there's evidence that neuropsychological assessments and neuroimaging independently and significantly contribute to the chances of an accurate diagnosis. But I've been at conferences where keynote speakers have talked about sparing people with dementia from assessment when it's obvious that someone has dementia. And the literature backs this up. It's generally the case that clinicians are more likely to follow diagnostic protocols the less severe the dementia that they're presented with. So this is the results of a survey by Wilcock and colleagues in the UK in 2008. And as you can see, the chances of particular elements of the diagnostic process being initiated either by GPs or by hospital specialists in order to reach a diagnosis of dementia are very, very small for some of the things that significantly distinguish between true and false diagnoses. They found that informant histories, which are lacking in 40% of dementia diagnoses, were actually a very significant factor in distinguishing between a misdiagnosis and a true diagnosis. Likewise, mood assessments were conducted only in about 40% of cases. 30%, sorry. 70% of dementia diagnoses were made without a formal assessment of mood, dementia, depression or anxiety. And so it's incumbent upon us as clinicians to really follow the protocols for diagnosis. There was a study in 2006, which is the only one that I've been able to find, which has looked at the efficacy of the clinical pathways like map of medicine. It did so incidentally. It was a study of the information that GPs gave to people they diagnosed with dementia. And as part of the study, the GPs were required to follow the memory clinic's diagnostic protocol. And in that study, the GP's rate of false diagnosis was only 11%, not 60%. So there is a real need to follow the clinical pathways properly when you are considering a diagnosis of dementia. So bearing all that in mind, how are we to understand the initial response to a dementia diagnosis? In 2007, Amanzada and colleagues pointed out that a dementia diagnosis is not only a medical process, but it's also a social process of removing somebody from the mainstream into what is unavoidably a highly stigmatized group in society.
First is denial. No way, because I'm not dying.
The difficulty of using the Kubler-Ross framework to understand people's reaction to their initial diagnosis is that it leads us to expect denial. denial is the phase that people have to work through in order to continue with their adjustment. And so any skepticism or pushback from the client as to their, the accuracy of their diagnosis, we can dismiss, which is fine if the diagnosis is actually accurate. But if it's not, it doesn't really help us find out. Avanzado was writing in 2007, 5 years after Badenoch's paper on resilience being the most common response. And they found much the same result, that most people's response to a dementia diagnosis was like Jim's stoic acceptance and resolve to make the most of the years remaining to him. The most common response was resilience, trying to live well within the diagnosis. The next most common response, again, like Badenoch's discovery, was that people went through acute emotional crises when they realized either the actual or possible implications of the diagnosis. In Jim's case, the driving ban. We can see why he would react much more strongly to that. And then there were a small proportion of people who reacted as we might expect from the Kubler-Ross framework, with what appeared to be denial. But Bunn and colleagues in 2012 cautioned against taking denial, what appeared to be denial, at face value. What they said was that a lot of people with a dementia diagnosis struggle to hold on to their identity and their autonomy. Jan mentioned before about the bus driver, the man for whom being a bus driver was the greatest thing in his life. And I actually worked with somebody in Scotland for whom the same thing. He had nothing else to show for his life, but the fact that he just acquired a PCV license, passenger car vehicle license, was the high point of his career. And it was so meaningful to him that when his license was taken away, we made special arrangements with the UK's DVLA for him to keep the license, even though it was registered as invalid. He wasn't allowed to use it, but he was allowed to hold on to the actual copy of the license because that was evidence that he had once had it. So people try to preserve their identity, people try to preserve their autonomy, but without a clear idea as to how to do that. Do you carry on as normal? Do you shut down? How do you maintain control of your life if you don't know the condition, if you don't know what's going to change? And so the risk is that people will start shutting themselves off. They'll start getting in first. Before their friends can reject them, they'll drop their friends. Before they can be relieved of occupational or leisure responsibilities, then they'll opt out. And again, this can look like denial and avoidance, an unwillingness to face the issue, when really they're trying to figure out what to do for the best. So by continuously engaging with people, monitoring their symptoms and helping them figure out what is the best response at this time, we can help them best manage the ongoing problems, especially considering that every time they make a decision as to what to stop doing or what to do instead, etc., in order to maintain the balance, the chances are they're going to experience further deterioration and they're going to have to make another renegotiation next month or 3 months' time or whatever else. We need to be there for them then as well. Now, in 2006, Van Hout and colleagues noted that GPs were twice as likely to give the diagnosis they believed to be correct to the rest of the family as they were to the person with the dementia that they believed to be true. This is in line with numerous studies of caregivers' opinions over the years. Percentages vary, but it tends to be something like 80% of caregivers are dead set against the person that they're looking after, their mum, whoever, being given a diagnosis of cancer or dementia, etc. But if it was them, they would want to know the diagnosis. The difficulty with the Kubler-Ross framework, which, as I said, was extended to families, applying it to the family's response to an initial dementia diagnosis, is that, again, it disenfranchises them. If they question the diagnosis, if they push back in any way, they can be dismissed as being in denial. But it also encourages them to set aside their own emotional reaction, because given that they are now responsible for mum or dad or husband or wife, their role as caregiver is to help shepherd the person with dementia through their own emotional reaction, to convince them that they have dementia, to get them past their denial so that they can get on with the rest of their adjustment. And so it puts the family in a very difficult position. Nevertheless, if we take the framework that I'm suggesting today, most families find the delivery of the diagnosis supportive. They find it useful. They find it reframes a whole load of points of conflict that have led up to the consultation. There can, however, be a certain amount of guilt. And again, several studies reported that family caregivers lamented their lack of knowledge of dementia, feeling that if they'd known more about the condition, they would have been able to identify these conflicts, these crisis points, as reasons to consult earlier. And so again, there's a little bit of self-blame there. So working with carers, again, continuously to decide what they need to drop and what they should be able to maintain, and that if they are going to drop an activity or a support or anything like that, what they're going to replace it with so that they can be as well supported as possible is our job. Because if we can help people experience a minimum amount of strain, they're far more likely to be able to stay the course. And included in that is, as we said before, helping people negotiate the stepping back from the closest of the relationship as the dementia deepens. Rebecca knows the answer to this, but I don't know if anybody else does. Anybody know what this is? It's the oldest surviving copy of the Hippocratic Oath. Now, everybody knows that the Hippocratic Oath is first, do no harm. Not this version. This version dates from about 200 years after the framing of the Hippocratic Oath, and do no harm is actually the third item on the list. The fourth item on the list is preserve patient's confidentiality. The second item on the list is stay within your scope and don't pretend to be a surgeon. And the first item on the list is provide free medical training to the sons of the person who trained you and make sure everybody else pays for the privilege. Nevertheless, most doctors work on the basis that first they should do no harm. And it isn't until very recently that misleading and withholding information from the patient were seen as acting in the best interests of the patient. So a lot of practitioners justify their withholding of diagnoses as being a beneficent act. Now, part of that, the difficulty with that, is that the Kubler-Ross framework makes the diagnostician and the other service providers into a passive observer. That if you choose to give the diagnosis, if you choose to trigger the stages of grief, then you can be there to handhold people, but really your only choice is whether to trigger that or not. If, on the other hand, you accept Badenoch's findings that people are mostly resilient to this, you can work alongside people to figure out how they will adjust their lives, both as patients and as caregivers, in order to deal with the various impacts of the condition as it progresses. And Brian Carpenter, in 2009, listed 3 reasons that clinicians give for not giving a diagnosis of dementia. And the first was, people aren't going to understand it. Like Jim, when we told him that he had vascular dementia, and he didn't realize what vascular dementia was. Or even if they do understand it, they're not going to remember it. Well, first off, deciding not to give patients information because our communication skills are poor is not really a good rationale. And secondly, again, as Jan said, it's always very useful to invite people to bring along supporters. There's a statistic which says that the norm is that people remember about 1/3 of what is discussed in a GP consultation. And that's without the shock of, I'm sorry, you have dementia. So I always take my wife along to consultations, she always takes me along. So statistically, that means we miss about 1/3 of the information. Carpenter said that in his research, about 50% of patients and 20% of accompanying caregivers left the consulting room believing that the patient hadn't been given a diagnosis of Alzheimer's disease when they had, which seemed to be primarily down to clinicians using euphemisms. And so it's incumbent upon us to get the information across, but also to realize that in cases where the diagnosis is a shock, it might be necessary to deliver the diagnosis in 2 or more sessions. The initial diagnosis, and then come back once people have had time to take it on board to adjust to the implications and discuss the implications then. The second reason for not giving a diagnosis is that there's not an awful lot that can be done for people anyway, medically. You heard Jan's review of the medication. Likewise, I've seen the occasional person experience a spectacular recovery short-term with donepezil, but the experience of the vast majority is that there's a slow and steady decline. But just because there's nothing that can be done medically doesn't mean to say that the person themselves and their family can't be doing things like putting in place enduring power of attorney, advanced care plans, discussing all sorts of aspects of the future, and if the diagnosis is delivered early enough, maybe even doing some of the things that they put off for later life that they're still in a position to enjoy. Travel can be difficult for people whose dementia has advanced enough, but there are all sorts of experiences that people had planned for themselves which they may still be able to do. And last, the other beneficence objection to giving people a diagnosis is that the diagnosis could tip the patient into depression or even spark suicidal thoughts. Now in 2009 there was a roundup of all the literature on dementia and suicide by Hoare and colleagues. What they found was that the risk of suicide in people with dementia was the same or even less than in people of a comparable age, but that it was elevated in the first 3 months after a diagnosis, and that the major risk factors were being younger, not having had a good response to anti-dementia medication, being depressed, and being hopeless. There was a study of completed suicides after a dementia diagnosis, which found that 2/3 of the people who completed suicide actually had comorbid depression. And so, of course, in your initial diagnostic workup of the person, you will have screened for mood, won't you?
You haven't mentioned so far the main reason why GPs withhold a diagnosis, and that's opening a can of worms.
Yeah, that's why I didn't mention it, because that would be opening a can of worms and it would be another presentation. Now, there was another paper which was specifically about that. It said the concern for a lot of clinicians was that if they were to give a diagnosis to someone in the early stages of dementia, this would lead to antagonism between the patient and the family members who brought them along for the assessment. And so to spare the family the conflict, they would leave the patient ignorant of their diagnosis. Again, brings you back to your point about consent and Jan's point about the capacity of the patient to make decisions about their own care.
What about the role of health literacy there? A lot of patients don't understand an awful lot about dementia and...
I think that there are a vast number of conditions that you could diagnose me as having, which I would need an explanation of in order to fully understand the implications for me. Dementia is one more. In spotting the signs, then yes. There have been various campaigns trying to raise people's awareness of the signs. I don't know if you remember, a couple of years ago, Alzheimer's New Zealand funded a TV campaign where there were paperback books stuffed in toasters and cars abandoned in the middle of intersections, etc. I'm not sure how successful that campaign was, but a general move to make people more aware of the possibility and the signs to look for would always be a good thing. So to sum up, because it is now lunchtime, dementia is a life-shortening condition, as we've seen. But the person that you give a dementia diagnosis on Monday isn't dying today. And so attempting to understand their reaction to the diagnosis in terms of a palliative care framework is inappropriate. But if we work with people to identify how their life needs to change and when, as their condition deteriorates, we can maximize their independence and quality of life, their caregivers' independence and quality of life, and also our chances of spotting whether or not we might have been in error in giving them the diagnosis in the first place. And by taking this approach at each stage of the transition, by giving the appropriate advice as to how to manage this particular level of care, we can continue to maximize independence, minimize carer burden, and head off the foreseeable challenges of the caregiver role. Especially in the early stages, people with dementia haven't necessarily lost the ability to lay down new memories which they can access. And so the earlier we give a diagnosis, the more control that we give people with dementia over their future. Thank you for your attention.